Good evening. It's a pleasure to be with you guys tonight. Being with a lot of friends that we've known for a long time. Ron has been a dear friend and inspiration for a lot of the things that you're going to hear tonight. But basically, we're going to talk about competent cultural communication care and principles and practice, and then try to dive into some pearls, principles, and pointers. The key question is it necessary? Is it useful? But we think having the right tools and techniques that you'll find the answer is yes. With that, when we talk about the presentation, we're going to do this in 4 parts. First is an introduction, try to engage your interests. Then we'll talk about part 1 is cultural competency in healthcare. Next will be active faith benefits for health and flourishing. We'll summarize a lot of the research for many years. Thirdly, patient engagement pointers in practice. Hopefully you'll find that's useful. And those of you that have some other pearls, share them with me at the end. Fourthly, practical principles and pearls. And without further ado, as Ron and I both had the privilege of training with Jim Rowsey, a dear friend of COS, Jim said the best pearl he could ever share with me was this: humility is the homage and honor your heart pays to the sanctity or God design of another human spirit. And that's what motivates behind what we're trying to talk about tonight. So to begin, cultural competency in healthcare and communication, does it matter? You decide yourself after you watch this.
Again, this is the USS Montana requesting that you immediately divert your course 15 degrees to the north to avoid a collision. Over.
Please divert your course 15 degrees to the south to avoid collision.
This is Captain Hancock. You will divert your course. Over.
Negative, Captain. I'm not moving anything. Change your course. Over.
So, this is the USS Montana, the second largest vessel in the North Atlantic Fleet. You will change course 15 degrees north, or I will be forced to take measures to ensure the safety of this ship. Over.
This is the lighthouse, mate. It's your call. Hello?
I think you get the point. So with regard to the introduction to the topics we're going to address, because we needed to get it for AMA credit approval, we want to hit cultural competence, but also there's a lot of references. Those that want this, we can give this to you by PDF because it has lots of references. But first, the diversity of religions around the world creates challenges for us as healthcare professionals and our systems to provide culturally competent whole person care. Specifically, proficient cultural competence requires the trained ability of healthcare professionals and organizations to deliver healthcare services that winsomely and adeptly meet the cultural, biological, psychosocial, and yes, spiritual religious needs of the patients and families. We're going to try to underscore that last part in a moment. Aptly equipping physicians and healthcare professionals towards engaging with proficiency in respective cultural competence and gracious patient interaction skills can really improve patient quality and healthcare outcomes. Moreover, strategies to move health systems towards these goals include what we're doing tonight, providing cultural competence training and developing policies and procedures that decrease barriers to providing culturally competent whole person care. So with that, again, the question is, do patients' interpretations of our communications matter? You decide.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday, Mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
So the question is, what are you guys thinking about? Hopefully you're engaged in wanting to listen to the talk. With that, obviously there are implications and consequences of cultural competence deficiencies. Included among these are this. Number one, if providers and healthcare systems are not working together to provide culturally competent biopsychosocial spiritual care, patients may have untoward health consequences, receive poor quality care, and be dissatisfied with the care they receive. Secondly, the quality of the patient-healthcare professional interactions is decreased. Thirdly, lower quality patient-healthcare professional interactions are associated with decreased satisfaction with you and I as the healthcare providers. Specifically, African Americans, Asian Americans, Latinos, and Muslims have reported in many instances, and they're cited here, that the quality of their care was diminished because of their ethnicity or race. So why should providers and systems be culturally and spiritually sensitive? What do the accrediting and professional organizations say about providing spiritual care? And this seems to be lost on a lot of providers. But did you know that 3 of the world's largest accrediting and quality organizations mandate spiritual care? The Joint Commission, International Society for Quality in Healthcare, National Quality Forum. So let's break this down a little bit. The Joint Commission accredits and certifies more than 21,000 healthcare organizations. It's our nation's largest and oldest accrediting organization. It was founded in 1951, and they require hospitals to be accountable for maintaining, as we all know, patient rights. But it also includes accommodation for cultural, religious, and spiritual values. And in fact, a little known fact that most people don't know that are providing health care is that in 2001, the Joint Commission revised its accreditation standards to require the documentation of a spiritual assessment. Let that sink in. So often that's ignored, not done. We want to do that artfully. Now, ISQA is active in over 100 countries. It works to achieve excellence in healthcare delivery and quality of care and develops principles for accrediting healthcare organizations, including the Joint Commission. They require that spiritual preferences of patients are recognized, and they guide organizations to develop processes that provide patients with access to spiritual care. Thirdly, the National Quality Forum is tasked by the federal government, the U.S. government, states, and private sector organizations to provide the best evidence-based approaches to improving care. And in that, they mandate the documentation of discussion of spiritual religious concerns. Think about that. Moreover, many other major medical professional organizations have taken positions that encourage members to provide spiritual care, including the American Association of Medical Colleges, American College of Physicians, American College of Critical Care Medicine, American Nurses Associations of Standards of Clinical Nursing Practice. So medical training associations encourage medical schools to train students to provide spiritual care, oftentimes neglected in our medical schools, as you know. But in addition to the Joint Commission, state and federal guidelines encourage institutional responsiveness to population diversity, as we all know. But these strategies are essential to meeting the federal government's what's called Healthy People goal, where we want to eliminate ethnic and racial health disparities. So in that context, institutions that seek or maintain the Joint Commission accreditation need to demonstrate expertise in cultural and religious competence. So with that, health systems and healthcare providers are developing strategies and techniques to respond to the various religious and spiritual needs of patients and families for many reasons. But one primary reason is this: healthcare professionals and systems must care for patients, as we all get it in a Christian community, as whole persons. Secondly, as we all know, healing is more than restoring anatomic continuity and physiologic homeostasis. We understand that health is a state of complete physical, mental, social, and especially spiritual well-being, and not merely the absence of disease or infirmity. We get that. COS gets that. We've been founded on that. Now, obviously, healing can include such things as restoring our ability to think clearly, experiencing stable emotions, maintaining positive social relationships, establishing a sense of value, wholeness, and purpose, and shifting from distorted worldly beliefs toward biblical truths. Truth is truth. But it's interesting to note that one Greek verb for to heal is sozo. In its full context, it means to save or to make whole, often used in the sense of total healing, body, soul, and spirit. So if you think about this, the ramifications, if healing only alters the physical processes, then people with distorted thinking, fractured relationships, and loss of personhood merely have stronger bodies in which to experience their brokenness. So in this context, this means it's important for whole person health care to include addressing the cultural and spiritual needs of our patients. So Somasi in 2002 defined the biopsychosocial spiritual model. And the way he described this is persons can be considered beings in relationship, and illness can be considered a disruption in biological relationships that in turn affects all the other relational aspects of a person. Spirituality concerns a person's relationship with transcendence. Therefore, genuinely holistic healthcare must address the totality of the patient's relational existence, physical, psychological, social, and yes, spiritual. So to break that down, healthcare professionals should be competently empowered with the knowledge and efficacious skills to effectively respond to the needs of patients and their families, particularly at intensely stressful times or end-of-life scenarios as outlined in this quality of life algorithm. So carrying this forward, as Christian healthcare professionals and ophthalmologists, we must see true healing as including not only physical healing, but also spiritual healing. This includes competently addressing the patient's body, mind, soul, and spirit. So let's look at this a little bit further. Scripture, as you all know, teaches there's three parts to us: spirit, soul, and body. The body is the material part of the person that constitutes the physical anatomy, flesh, bones, and blood. The soul is the immaterial, rational part of a person that produces behavior through the mind, will, and emotions. And the spirit refers to the immaterial, innermost part of a person. The human spirit needs to be made alive to God, communes with God, can live with Jesus forever. And a man may be complete as to body, soul, and spirit, but his spiritual nature will remain unregenerate until the Holy Spirit enters and takes possession of the spirit compartment of his nature. That happens when the new birth takes place. And so if you think about this, so this is a nice diagram that I like, because humans are composed of spirit, soul, and body. But if you look at this, realize that our spirits are designed to be united or joined to another spirit. That's how God made us. So if you think about the big picture, God's plan from the beginning, from the Garden of Eden, was that we could be in daily communication with him and he would grant revelation knowledge into our hearts. Satan's plan, however, was to tempt man to live out himself, to figure things out on his own without divine revelation. So, before we invited Jesus into our hearts to be our Lord and Savior, the Bible tells us that we had, according to, this is the Amplified version here, evil spirits working within us, quote, "You are obedient to and under the control of the demon spirit that still constantly works in the sons of disobedience." On the other hand, once we're saved, the Holy Spirit is joined to our spirits, and quickly his work within us quickly grows and expands. So, the Holy Spirit's chief purpose is to be our lifelong guide, and if we follow him, we're actively engaged in spirit-led living. So instead of God being some remote, stern figure in the sky, as many religious people seem to view him, he speaks to us and guides us through his Holy Spirit, which means God is anything but impersonal. He's a personal God, as we all know. And he will guide us, and this is the catch, if we'll just listen. I have a hard time doing that. The Holy Spirit primarily guides us, and these following scriptures serve to establish the fact that not only do we have the Spirit man, but the Holy Spirit is the one that can guide us through that inner man. Romans says, "For as many as led by the Spirit of God, these are the sons of God. The Spirit himself bears witness with our spirits that we are the children of God." And this verse, I think, really captures the essence of what I'm trying to communicate on this point. And that is, the spirit of man is the candle of the Lord, searching all the inward parts of the heart. Another translation reads, "The spirit of the man is the lamp of the Lord." Well, let me break that down. Sometimes we look at our circumstances from a mental standpoint and try to reason things out. But God doesn't guide us through our intellect. And note well, when you look at this verse expressly states, the spirit of man, not the mind of man or the soul of man, is the candle of the Lord. This means that God will lighten us. He will guide us through our spirit, but we have to be yielded. We have to submit. And I believe this is the number one way God leads us, through the inner man. And as a believer, God's Spirit communes with your spirit, so we must learn to listen to His Spirit through our spirit, and we need to be certain and confirm it aligns with Scripture and or the biblical principles before fully receiving it. Okay? So what are the keys to hearing God's voice? I think there's 4 keys specifically outlined in Habakkuk. Habakkuk 2:1-3 says, I will stand on my guard post and station myself on the rampart, and I will keep watch to see what He will speak to me, and how I may reply when I'm reproved. Then the Lord answered me and said, record the vision and inscribe it on tablets, and you can read the rest. So here's the 4 points. Number 1, we have to be still. That means I'll stand on my guard post. Secondly, we need to fix our eyes on the Lord, not on what the world's doing. That means I will keep watch to see. Thirdly, He's going to speak to us, but we have to yield, right? We need to tune to the Spirit speaking to your inner man. And fourthly, the Lord answered me and said, record the vision. So where am I going with this? Why are you making this? I encourage you guys to think of a practice that I call two-way journaling, where you write the flow and thoughts of the pictures that light upon your spirit, heart, and mind, but it must always confirm with the light of Scripture. So one of the things you got in your gold bag is a prayer journal, but you could put your requests down there and then listen, be still. Then you can write down what the Lord is saying to you. This is the only way I can get my mind still. I get distracted about all the stuff, responsibilities you have to do. This allows me to focus and really dial in, because otherwise it's too easy to get distracted. Where is the world and all that stuff that Jesus says? So that's one thing, that's one reason you have the prayer journal. So hopefully you'll use it and consider two-way journaling. Certainly changed my ability to focus and listen. Now, what about culturally competent medical care? Well, the goal of this is whole person care. And we want to provide consistent quality of care regardless of the patient's cultural, ethnic, racial, or religious background. Secondly, when individuals and systems are able to provide a positive environment of cultural competence, that means the religious and spiritual needs of those who are cared for, the outcome for patients then improves, and the healthcare system as a whole becomes a more positive environment. Strategies for improving cultural competence in these settings include encouraging the family to participate, incorporating cultural specific values, providing an environment that allows traditional hearers and integration, providing interpreter services, recruiting minority staff as you need, and providing cultural awareness training like we're doing now. We need to be smart. That begins with cultural awareness. Are we aware of our own biases? Developing cultural skill, improving our cultural knowledge, improving its skill through cultural encounters, and then at the root of all of this, dovetails into cultural desire. What's your desire? What's your want to with regard to cultural competence? It's an integrative process. What I mean by this is that if you look at this diagram, lower right, and you look at cultural desire, it's based in love, caring, teachableness, and humility. And they all integrate together, and that's all together this process, right? It's all part of this integrative process that we need to seek. Now, part two is cultural competency proficiency acknowledges active faith benefits for health and flourishing. The data is in our corner when we talk about integrating cultural competency with the background of the truths that we know. So Christians long attest faith benefits health. And the data on the relationship of health and faith shows that the most important factor is religious practice and belief. Not at all not denomination. Sometimes it does help in that regard. But the bottom line is this. Patients who don't just talk the talk, but walk the walk, demonstrate the most benefits. So what does the research literature show? And this is accumulation of data that spans from 1887 to 2010, specifically concentrated on what's reported on the Handbooks of Religion and Health, which is kind of the definitive resource. Senior editor is my dear friend Harold Koenig, 2001, 12, and 24 editions, and research particularly concentrated in the 2010 to 2016. And this data is summarized. You'll see the percentages of positive, percentage of negative, but overwhelmingly you're going to see the benefits. So let's look at depression, the most common emotional disorder in the world. Religious involvement is related to less depression, faster recovery from depression. Religious involvement with regard to suicide shows less suicide and more negative attitudes towards suicide. In fact, the suicide incidence substantially lessened with increasing religious service attendance. And if you look at alcohol use and abuse dependence, less alcohol use, less abuse, less dependence. And you can see this is 90% of the best designed studies support that. When we look at illicit drug use, religious involvement is related to less drug use, abuse, and dependence. 86% of the best designed studies and 95% of the randomized controlled trials. Religious involvement is related to greater well-being and happiness. Religious involvement is related to greater meaning and purpose, greater hope, greater optimism. And when you look at these together, all of these have consequences for patients' motivations for self-care and efforts toward recovery. That's what we're about. Religious involvement is related to greater social support. Religious involvement is related to less cigarette smoking, especially among the young, in 90% of the studies. Amazing. Involvement is also related to better immune function, better endocrine functions, and when we look at cardiovascular functions with the systematic review, religious involvement is related to lower blood pressure in 57%, more than half, and again, more than half the studies for better cardiovascular functions and less coronary disease in more than half. In fact, when you stratify this and you look at high attendance, high prayer, lowering of diastolic pressure in over 3,000, almost 4,000 patients over 65, the p-value was less than 0.001. One of the things I thought was really fascinating is that there was an MRI, functional MRI study done where they looked at brain cortical thickness in religion spirituality. And if you see on the left where religion is not important, you see the reduced cortical thickness. But where it is important, you don't see that. Our Maker knows what's good for us. We should implement those practices. And if you look at all-cause mortality, greater longevity. This was in a study of almost 75,000 women. You could look at death rates from cancer, and you're stratified by these things. Less cardiovascular mortality again, and the more religious service attendance, the better it is. Lower cancer mortality, same thing. If we look at exercise, weight, and risky behaviors, this is kind of an interesting thing. Obviously, religion is related to more exercise, physical activity, less extramarital sex, safer sexual practices, but unfortunately, these get-togethers like COS, church barbecues, guess what? Heavier weight. We didn't win on that one, but we won on all the others. So eat up out there. We can't change it. So, part 3, patient engagement pearls and pointers. This has to do with our patient interactions. And as many of you guys that are old enough, you know who Will Rogers was. He was a famous actor and social commentator, and he once said this: you don't get a second chance to make a first impression. Often people, as you know, patients, make split-second decisions, including whether they like or trust you, based on your appearance. As Ron knows, Jim Rowsey used to always tell us, you know, when you speak in public, wear that tie. If you see a patient, wear the tie. So in honor of Jim, we're wearing the tie tonight. Now, Mae West, famous actress, she says, I speak 2 languages, body and English. So now we're going to delve into this. But first, as a preface, Morabian did some really cool work. And did you know that 93% of all daily communication is nonverbal? Let's break it down. 7% of any message is conveyed through words, 38% through certain vocal elements, 55% through nonverbal elements, including facial expressions, gestures, and posture. So the major impact is not so much due to what we say, but how we say it. The visual and vocal have a greater impact than merely words, and this transcends all kind of cultural norms, and we'll talk about some specific variables, but this is important. So we want to do some basic understandings with body language, which is almost universal for most of these. The first one is the shoulder shrug. And as I go through these, you can kind of look at these different pictures and stuff, and I wish we had more time, but we were trying to streamline what we want to get through. First, the shoulder shrug. It's a good example of a universal gesture that's used to show that a person does not know or understand what you're talking about. And it's a multiple gesture. It has 3 main parts: exposed palms, hunched shoulders, raised brow. Next is the ring or OK gesture. The OK meaning is common to all English-speaking countries, and it means all correct. Next is the thumb up gesture. Now, interestingly, in Britain, Australia, and New Zealand, the thumb up gesture has 3 meanings. 1 can mean an OK signal. 2 can commonly used by hitchhikers who are thumbing a lift. And 3rd, when the thumb is jerked sharply upwards, it means an insult. It's a signal meaning up yours or sit on this. In some countries, such as Greece, its main meaning is get stuffed. So that's why being aware of these different cultural norms is important. Now, what about rubbing the palms together? This is fairly universal. It communicates positive expectation. Now, arm crossing gestures, and I wish we had time to break these down. You can see the different pictures, but basically, it's a common posture whereby an individual will casually fold arms across the chest. but it most often signifies to the patient or someone you're interacting with a defensive or sometimes insecure attitude. It's common among strangers, elevators, lines, anywhere people feel uncertain or insecure. And so you can see disguised nervousness and things like that. It may be in response, however, to the cold if both hands are tucked up into the armpits. So, what about palm positions? Submissive, dominant, or aggressive? Let's break these down. First is the submissive palm position. In this case, the palm is facing up. It's used as a submissive, non-threatening gesture. It signifies appeal or request to others. It's reminiscent of the pleading gesture of a street beggar. And the application for us is this. The patient or technician being asked to move the box will not feel that the request is given with pressure in a normal superior-subordinate situation, will not feel threatened by the request with the palm up. Historically, an open palm has signified honesty, truth, allegiance, and submission. In contrast, the dominant position of palm down, where you're kind of exerting this desire to hold down something down, is occurring when the palm is turned to face downwards and you're exercising immediate authority in that situation. So, if you're doing that gesture with the technician, the nurse or staff or patient to whom you're directing the request feels that she has been given an order to remove the box and may feel antagonistic towards you, depending on your relationship with him or her. They may comply, but they may not like it, how you've expressed it. So if the person to whom you gave the request was a coworker of equal status, he could reject your palm down request and would be more likely to carry out your wish if you'd use the palm up position. So if the person to whom you gave the request is your subordinate, the palm down gesture is acceptable as you have the authority to use it, but it doesn't necessarily connote positive feelings when you do it that way. What about the aggressive palm position? The palm is closed into a fist, and the pointed finger becomes a symbolic club with which the doctor or speaker vigorously beats his listener into submission. So in this case, the pointed finger is one of the most irritating gestures that a person can use while speaking, particularly when it beats to the time of the speaker's words. So if you're a habitual finger pointer, try practicing the palm up or palm down positions. You'll find you create a little more relaxed attitude and have a more positive effect on other people, especially your patients and nurses. Now, what about head gestures? So if you look here, we have these three different positions. We'll break these down. The neutral head position is the position taken by the person who has a neutral attitude about what you're hearing. And oftentimes the head will remain still and may occasionally give small nods. The interested head position in the middle is where the head tilts to one side and it shows that interest has developed. You'll see oftentimes with reporters and interviewers doing this, nightly news people. The disapproval head position is when the head is down, the chin's down, and it signals that the attitude is negative, even judgmental. Critical evaluation clusters are normally made with the head down. And unless you can get your patient or person's head up or tilted, you may have a communication problem. So what about the backward head tilt? Well, that gesture generally indicates a perceived superiority and sometimes contempt for people he or she is interacting with. And this is probably what gave rise to the sayings like looking down his nose at someone, or she has her nose up in the air. Now, what about controlling a patient's gaze to help aid retention? One of the things is you can use a pen to keep control of the patient's gaze. Now, how do you do this? When you're giving patients a visual presentation using books, charts, graphs, iPads, or others, as we're apt to do in ophthalmology, research shows that of the information relayed to a person's brain, 87% comes via the eyes, 9% via the ears, and 4% via the other senses. So to maintain maximum control of that patient's gaze, use a pen or pointer to point to the visual aid and at the same time verbalize what they see. So next, you then lift your pen from the visual aid and hold it between his eyes and your eyes. And what happens is there's this magnetic effect of lifting their head so that their chin's no longer down and they're looking at your eyes and now he sees and hears what you're saying. That helps achieve maximum absorption of your message, particularly if something's kind of important. Now, what about shaking hands? We do this all the time. We'll break this down. I wish I could go into more details. There's a lot of fun with this, but the basic stuff is there's three basic attitudes transmitted through the handshake. One is the taking the control, one's giving the control, where it's submission, and the last one's equality. The top one's dominance. And in that case, dominance is shown by turning the hand so the palm is facing down during the handshake, as you'll see in the upper right. Next is submission, and that's shown by turning the hand so the palm is facing upwards during the handshake. And amazingly, you'll see like Trump, a lot in his stuff, you'll always see him doing this to try to yield that way. It's kind of political maneuver. So next is equality, shown by turning the palm so that it faces neither up or downwards. Now, what about hybrid handshakes? One is classically called the glove handshake. In this case, it's demonstrated by the initiator clasping both hands around the recipient's hand. It's intended to give the impression of companionship and warmth, sometimes referred to as, quote, and it's not Eugene, politician's handshake. Initiator tries to give the receiver the impression that he is trustworthy and honest. We know Gene's trustworthy and honest no matter how she shakes our hands right. But when this technique is used on a person he has just met, it has the reverse effect. And we're going to get to this in a second, but notice this is Gorsuch with Trump. Look, he has the stiff arm, he's doing the double pat, and you want to break this down. But anyway, we'll get to that in a second. In this case with the glove, the receiver feels suspicious and cautious about the initiator's intention if it's someone you just met. It should only be used with people to whom the initiator is well known. With elderly patients, this may be okay. Younger patients, however, we need to use discretion. Now, the double-handed handshakes, there's the wrist hold, the elbow grasp. Intention is basically trying to show sincerity, trust, or depth of feeling towards the receiver. So the two significant elements should be noticed. First, the left hand is used to communicate the extra feeling that the initiator wishes to transmit. Its extent is related to the distance that the initiator's left hand has moved up the receiver's right arm. The elbow grasp transmits even more feeling than the wrist hold or shoulder hold. But note, this wrist hold or elbow grasp are acceptable only between close friends or relatives. As doctors, providers, we need to exercise caution with that. Now, what about the dead fish handshake? We all know about that. That's the limp handshake, has no energy, no shake, no squeeze, gives the feeling you're holding a fish. It's the hallmark of passive handshakes. We want to avoid that because it carries negative connotations. It's generally considered to demonstrate weak, apathetic, basically uninterested, submissive individual, low self-esteem, so forth. But it can be a traditionally acceptable handshake for women, particularly in certain circumstances. The straight arm extension handshake, as you saw with Gorsuch and Trump, here in this case, the initiator of this handshake will offer a straight extended arm in greeting. Its primary purpose is to maintain distance and formality. And sometimes people from rural areas who are used to keeping their distance will use this handshake. I'm not sure if they're doing that with Eugene when you're meeting him. By the way, she's knocked on 21,000 doors. It's amazing what this lady has done. I mean, just incredible. The fingertip clasp is similar to what we talked about, the dead fish, but this occurs when one party stops short of grasping the other participant's palm and instead clasps their fingers. And sometimes this is okay, but oftentimes it happens when one party misses the mark due to lack of confidence, esteem, or nervousness, not fully engaged. So when it happens, it puts off the receivers because the patients think you're not interested or engaged. Sometimes it's used, however, in a more formal setting when people want to maintain spatial distance and less intimacy, like we see with the Queen here in the lower right. Now, how do you control the impressions you make? Well, the first thing is, it's what you don't say that counts. We try to want to read and understand our patients through nonverbal communication. This is true across all cultures. And sadly, I think this drawing from the 7-year-old, and when you see it and you know the story behind it, you kind of want to cry. This is a little 7-year-old drawing what's going on in our hospital room. And what she's drawing is the doctor absorbed with the computer instead of facing and looking at her. Meanwhile, her family is trying to comfort her. Pretty powerful drawing, I think. Makes the point. So, patients remember more of what they see than what they hear. Long after our meetings with them, they are likely to have forgotten the exact words someone's used, but they may retain a vivid image of the same person's facial expression. So, as we depart this earth, we'll leave everything behind except the influence and impression we've made on others. And I believe the Lord wants us to love each other. That's, his two greatest commands, love God, love our neighbor. So he wants us to practice this. And in practice, this means we need to love our patients, love our students, love our techs, love our nurses, love our staff, love our colleagues. In just a few words, be nice to people. Treat them as you'd like to be treated. Be nice to the nurses, right? Be nice to the technicians. And that means if you need an instrument during a minor procedure, ask with please and thank you. Don't just say, hand me that. We should be courteous and try to exercise wisdom in our listening. The patients want to know, are you listening to me? We want to smile engagingly and warmly. Keep eye contact. And if we're in a clinic meeting, patient conference room, or giving a training presentation, we want to make it a point to make eye contact with each one of the people involved, unless, of course, it's physically impossible because it's a packed house or room or so forth. We want to look professional from the outset, meaning be welcoming and stand with good posture, right? Walk confidently, chin parallel to the ground. Don't shuffle and drag the feet. Keep the shoulders balanced, the stomach and buttocks in line with the rest of the body. So in maintaining good posture, that means no slouching, no slumping. And we want to keep the patient in the power position. Try to get them above you to the extent you can, particularly if it's a sensitive situation. Eye level with kids. But if patients are angry or upset, especially important to get below their eye level. You want to let them talk down, you little boy. Let them talk down, you little girl. And once they've done that, they feel better. They vent it. It's amazing how to alleviate some of that. We'll talk about one of the Rowsey rules in a moment. We want to maintain interested contact, and what that means with good eye contact means no wandering, darting, downward, drooping, rolling, squinting, glaring, staring, or disinterested eyes. Our focus needs to be the patient. We want to remain engaged and appropriately attentive. And I know you guys know this. But we don't want to be checking the time or inspecting our fingernails. We don't want to have our hand on the doorknob like we're leaving. It's nice to have your legs crossed when you're talking to the patient, and then you know you're not getting ready up to leave. So we don't want to be not directly facing the person we're speaking to the extent we can. We don't want to be looking down while in the presence of others. We don't want to fake a smile unless it's being forced for the camera. And remember the power of touch when we're shaking hands, because using an engaging, genuine, polite, professional, appropriately firm, welcoming handshake, and especially greeting, is important. Because time, touch, and attention communicates caring. Patients appreciate the first few seconds of a sincere welcome and not a drab, hello, what brings you in today? Instead, we want to say, welcome, Dr. Kruger. Now the focus is on the patient. Then you can introduce yourself. They want to know that you're there for them. It's not about us. Like if we say, I'm Dr. So-and-so, what brings you in today? That's not putting the focus on the patient. Jim would always go in and greet the patient, welcome, and he'd have joy in his voice. And we need to be that kind of ambassador. We want to face the patient to the extent we can. So when you wash your hands, don't turn your back on them. Look at them, engage them with a social history to use your time wisely. And that's important. You want to engage them on something personally meaningful to them. And then listen. And then listen to whatever they have to say for the first minute. And Ron knows this. We call it the Rowsey rule. Without interruption for 1 minute, let them talk about whatever they want to talk about. As you probably know, the average length of time given patients to itemize their concerns before the first physician interruption and redirection is 18 seconds. Surgeons, we're not the most patient. We want to use a gentle voice, joy in our voice, lower the volume of the voice, and slightly slow the speed of our voice at the end of a sentence. We want to speak to them like they're royalty. Keep our feet and knees toward the patient, especially important when our torso is working on a keyboard or monitor position to the side. It makes them feel you're more engaged with them. Shoulders parallel to the patient to the extent we can, mirror the face of the patient, because copying their gestures is a means by which one person tells the other that they're in agreement with the ideas and attitudes. One's non-verbally saying to the other, as you can see, I think the same as you, so I'll copy your posture and gestures. And if you wish to develop an immediate rapport and create a relaxed atmosphere with a new employee, you need only copy the employee's posture to that end. Achieve that. And it's possible to influence a face-to-face encounter by copying that positive gestures and postures of the other person, if it's positive, right? And it has the effect of putting the other person in a more receptive and relaxed frame of mind as they can see that you understand their point of view. So I say lean toward the patient. Lean your head toward the patient. I'm going to repeat this several times because this communicates engagement and interest. Lean your head toward the patient. Lean toward the patient. I think I've made the principle, but you get the point. And then open hands. No folded arms, because the folded arms are closed attitudes, right? Keep our hands out of our pockets. Hand to the heart's okay, Because standing with our hands in our pockets may send undesired signals to those around us. Probably none we intend, unless we are trying to look less confident as we're trying to hold ourselves back, or bored, or hiding something. Otherwise, we should take our hands out of our pockets. Now, what about hands away from the head? You want to keep away from the mouth, the necktie, when we pull on the collar like the Rodney Dangerfield thing, because these are all associated with deceit gestures subliminally. It's the whole hand to mouth, ear and eyes associated with hear no evil, speak no evil, see no evil. So I wish I could break that down, but you can see the pain in the neck gesture and all those kind of things. So in ophthalmology, we like to say as you approach a patient's face, do it delicately, as if you're picking up the wings of a butterfly. And we should pause when speaking. Pause at commas, pause at periods, pause at paragraphs, pause before and after an important word. This provides appropriate emphasis. Pauses to the you know, and make you sound more persuasive. We need to let our patients finish their sentence. Pause after they finish the sentence, because what happens in that case is it communicates, I'm not only listening, I'm considering seriously, excuse me, I'm considering seriously what you say. We speak too quickly, it's basically saying, I have not been listening, but I have the following rebuttal. We should eliminate but from all conversations. Put our pen down. They know we have to pick up our pen before we leave, so that also communicates that we're not in a hurry to get out of there. No clenched teeth, easy on the garlic, exercise gentle and respect. Quiet in the room. And then I suggest developing a new habit with students, staff, techs, and it's this. You're trying to address a problem as doctors. We often will ask why, because you want to know more detail. But instead of asking them why, reframe the question so it starts with what. Instead of, why did you do that? Ask, what were you hoping for here? Instead of say, why did you think this was a good idea? Ask, what made you choose this course of action? Instead of saying, why are you bothering with this? Ask, what's important for you here? Stick to questions starting with what to the extent that you can, and avoid questions starting with why. It takes a little more thought to do it, but it's great for coaching conversations with staff and students. And this way you're more of a coach and less of a boss. You'll be respecting them more, loving them more, motivating them more, treating them more like our Lord treats us. The smallest thing, when done for the love of God, is priceless. And Jim also said, one of my favorite quotes from him, if love doesn't solve the problem, then increase the dose, no matter how difficult the patient. That was always his answer. And boy, he lived it. Part 4, practical principles and pearls to help infect enlightening engagements. As you know, cultural competency recognizes we're in a contemporary and culturally diverse society with spiritual warfare forces in play. So when we talked about spiritual history, and in the back, you have 4 different ways to do this. And one that I like is the FICA method, the spiritual history inquiry format, and this is a modified version. F is, do you have any kind of faith practice? I is spirituality, religiosity important to you? C, what type of community support social systems do you have? And A, do you need any assistance, or would you like any assistance to you in this capacity? We need to be shrewd as serpents, but innocent as doves. And you'll see in this appendix, there's ways that you don't want to be proselytizing, but you want to render appropriate spiritual support. And it's a fine line to do this right. And we have that illustrated there for you. But all 4 methods. I wish I could go through more patient-centered cultural competence principles, but I want to point out 2 things. Again, the appendix has more information. But principle 4 is words can harm and words can heal. If we say there's nothing more we can do for you, that's inaccurate and harmful. Instead, we should say, I wish we had better treatments for you. I think we need to focus on your quality of life and dignity. That's healing. We need to be clear, avoid jargon, and keep explanations geared to the patient. People need the truth delivered sensitively. We want to balance optimism with credibility. Also, physical touch is a powerful force that can be destructive or healing. If we're a man, we should try not to extend our hand to a woman unless she sends hers first. Now, there's lots of other principles I wish we'd go through, but we need to properly understand truth. Because this matters in relationships, this matters in understanding, this matters in cultural competency. What's truth? Truth consists of ideas or statements that match what is reality. It's non-contradictory, absolute, discovered, descriptive, inescapable, unchanging. So when we talk about worldview beliefs, there's big three categories: atheism, naturalism, where truth is relative, no absolutes. Pantheism is relative to this world, and for those that are theists, absolute truth exists. I wish I could break down more, but for sake of time, it's important to know that the Barna, they've done these surveys. They did this a decade later where Christians were more perceived positively, but in 2006, and it's even worse now, what's the impression of Christians by unbelievers? Basically, 90% see us as anti-homosexual, 87% judgmental, and 85% we are hypocritical. So we have to be aware, culturally aware. So how do we overcome this? Well, Jesus artfully used questions. And I'll tell you, a lot of my mentors, some of my favorite people, my dear friend Sean McDowell, that's his wife Stephanie, and then you see Sean with his dad, Josh McDowell, many of you know him. One of my great friends and mentors in this is John Lennox, who's at Oxford, and I had the pleasure of training there. Then Hugh Ross with Reasons.org. But one of the really great apologists, he's out on the West Coast, and Greg Kuchel, and he champions the Colombo approach, where you use three questions. What do you mean by that? How do you come to that conclusion? Can you clear this up for me, or have you considered? And the initial goal is you're trying to put a stone in their shoe. You're trying to make them think, like putting salt in their water. And if I could summarize, the one thing I would like you to take away from this talk is this. To the extent that you can, never make an assertion when a question can make the same point. Never make an assertion when a question can make the same point. The reason is this: questions are interactive, inviting others to participate. Questions display interest in the other person being asked, and in most settings, this is a great boon to their pride and their self-worth of that person. Most people are not queried on many, if any, subjects. Their opinions are not solicited. Questions make headway without requiring you to state your case. Questions shift the burden of proof to the other person. They respectfully allow you to move your case forward without preaching at them. Winsome, humble inquiry-type questions, respectful questions treat others as God's image bearers. That's who they are. So let's talk about the law of non-contradiction, because this helps one discover what's false. Because opposite ideas cannot both be true at the same time in the same sense. Is the earth round? The earth is not round. So obviously, when we talk about does God exist or does not exist, well, they both can't be right. Now, obviously, we have John, of course, dear friend at Oxford. And so when we talk about this law of non-contradiction, it's undeniable, and even those who deny it use it. So let's break this down a little bit, how you can use this. Basically, all truth is absolute. Something that's true is true for all persons at all times, at all places. So there's lots of objections to absolute truth, as you know, in our society more than ever before. They say there's no truth. You can't know the truth. All truth is relative. It's true for you, but not for me. No one has the truth. You ought not judge. Okay, so how do you engage these people? You want to do it winsomely, but our greatest tool in answering objections is to apply the claim to itself. So, for example, if someone were to say to you, I can't speak a word in English, didn't he say that in English? We call that the roadrunner tactic, because the person making the claim has no ground to stand on. So again, when they say there's no truth, is that true? So you look like a genius. You're putting a stone in their shoe, right? There's no such thing as an absolute truth. Are you absolutely sure? You're making them think. It's true for you, but not for me. Is that true for everybody? You should doubt everything. Should I doubt that? There's no truth in anything but science. Is that a scientific truth? You ought not judge. Isn't that a judgment? So Ludwig Wittgenstein, he said all God talk is meaningless. So if you're engaging with someone like that, you'd say, is that God talk meaningless? Again, you're applying the claim to itself, reversing it back. If they say all religious beliefs are true, you can say, my religious belief is that all religious beliefs are not true. Is my belief true? You shouldn't impose your moral values on others. Is that your moral view? David Hume, an Enlightenment thinker in the modernist sense, he said, only self-evident or empirically verifiable claims are meaningful. You could say, is that claim self-evident or empirically verifiable? That's just your interpretation. Is that just your interpretation? Bart Ellerman is at UNC in our neighborhood, so I'm adjunct faculty. I was tenured there, and now I'm the vice chair of surgery at Campbell's Medical School. But Ehrman's well known in the circles. He was a Christian and then walked away. He says the reader determines the meaning. Should I determine the meaning of that? So when we look at those three major religious worldviews, theism, God made all, pantheism, God is all, and atheism, no God at all. And you'll see in your thing in the back, we have breakdowns of these major religious things and what their health issues are, and I hope you'll look at that. But with Immanuel Kant's case, he says, you can't know the real world, in the Enlightenment. So then how do you know the real world is there? Kant's nothing but claim actually requires more than knowledge. So there's nothing but phenomena but from the real world of my brain, but it's not in the real world itself. So in order for Kant to distinguish between the phenomena in his mind and the real world, he must be able to see or know both. But he claims knowing the real world is impossible. But this nothing but is a fallacy, right? Nothing but statements imply more than knowledge. Example from Kant is where information that gets to your brain is nothing but phenomenon. But in order to know that, Kant would have to know more than just the phenomena. He'd have to see beyond the phenomena into the real world, the noumena, in order to distinguish the two. But knowing the real world is what he says can't be done. So, you can't know the real world? And how do you know that about the real world? You apply the truth claim to itself. And there's other ones like that, we'll do it. Now, Jack Nicholson, that famous movie, You Can't Handle the Truth, as you guys may remember. But truth is really telling it like it is. But contrary beliefs are possible, but contrary truths are not possible. You can believe everything is true, but everything can't be true. Objective truth can't be denied without being affirmed. So to review this a little bit, to help this sink in, the Colombo technique, you want to ask, what do you mean by that? How did you come to that conclusion? Can you clear this up for me? Have you considered? Trying to put the stone in their shoe, a little salt in their water so they want to drink some more. So a little advanced practice here for this technique. You should only believe things that are empirically verified. Is that empirically verified? There isn't the truth, only my truth. Is that just your truth or the truth? You ought not impose your morals on people. Then why are you imposing that moral on me? You can't trust the Bible because it was written by men. Then why should I trust that? You're just playing word games with me. Is that just a word game? And notice her palms up, appealing. Asking graciously, humble inquiry. Consciousness is just an illusion. Wouldn't you have to be conscious to know that? He's got the shoulder shrug, palms up. One of my favorite verses in the King James Version is where they're describing Jesus, and it says, he made himself of no reputation and took upon him the form of a servant and was made in the likeness of men. And that's the thing, as providers, we need to remember to check our egos at the door. It's not about us. And in that mindset, humility manifested compassion brings healing, even without our doctors around. And I know you guys all know that. You guys are doggone good. And I want to thank you, these COS colleagues, for so many years. We loved Lawton and Brad Ferris, and so many people have meant so much. I just thank you for your example of commitment. I want to just again point out that these appendices, and the one with the 3 stars where it says major medical clinical considerations for physicians' cultural competence awareness according to the patient's designated religious affiliation, is really worth looking at. Also, you'll see the 4 stars is the helpful tables of practical questions for suggested use in major religions and cults with regard to cultural apologetics conversational dialogue. And then you'll see there's the Pew Research tables from 2024, the spiritual diagnosis decision pathways, just 1 star, the spiritual history inquiry examples, spiritual care consensus report for outpatient and inpatient algorithms, spiritual health intervention examples, the relational excellence pyramid, and then effective cross-cultural communication negotiating modeling. But I like the ways you do the spiritual history, but the ethical principles you'll see at the top, like how we define these, So you'll have it there, and you can look that over beyond the scope of what we could go over tonight. But I just wanted you to be aware of that. With that, I just want to say stay strong and enthusiastic. It's awfully great being with you. I love coming here and seeing some of the people I admire the most, certainly in ophthalmology and certainly in medicine. It's great being with you. And even though we said it can be challenging and dirty, go out there and be amazing, as you always do. Thanks so much for your attention.
Questions?
Yeah, you said that would be available by PDF. Is that correct?
Yes, actually, if you will go to Renee and write out your name, and if you want to get it tonight, I'll just airdrop it to your phone. If you'll find me, I'll just airdrop it and you'll have it. There's some other handouts we'd love for you to have, because the PDF has all the references with it. I'm honored to do it, so you actually have those there. And then you can use this knowing that spiritual history is mandated. It's kind of a key thing. Many administrators don't know that. When I first got to UNC, I started my career at Duke, and when I was at UNC, the administrator, he was homosexual. He's like, "You're trying to start evangelism, you can't do that." And I was trying to get him to spiritual consults and stuff like that with the chaplains to have them prayed for before every surgery. So
I was interested. I was doing a little research on our policy at Mayo, and that's one of the approaches that we do is, it's down there that we're supposed to be addressing the spiritual needs of our patients as well.
And you see, I have all the references there. When you have the PDF, you'll have them all for a joint commission and so forth. You'll have all the references, and you have the links. Pretty sure I have the websites in it. Yeah, there's so many references there. Gene said, make sure you get this for AMA approval, so you'll have them.
Craig, Stan here. I just picked up, Jim Rowsey made a huge difference on your life. And what I've noticed is that every single fellow that I've ever met that worked with Jim that year changed their life forever. Did you do a fellowship with him, Ron? Is there anybody else that did a fellowship with Jim Rowsey here? So I didn't do a fellowship with Jim Rowsey, but when I started Christian Eye Network, I said to Drew, my brother-in-law, I said, we're going down to meet a couple ophthalmologists. And we went down, and Jim Rowsey had invited us down to Jim Gill's clinic. And we had a whirlwind weekend, as you can imagine, and Jim Rowsey just so impressed me. I was like, man, I wish I would have done a corneal fellowship. Because Jim is unparalleled. He's like one of the old guard of this society. And Jim, we'd be walking down the hall, and all of a sudden Jim would stop. He'd say, "Oh, Gene, God bless you today." And he would just give her a big hug, and he would say, "Can I pray for you right now, Gene? Let's just pray." And we're in the middle of the elevator, and there's patients walking around us, and he'd be praying for the patient. What an inspiration. And I'm just thankful that you're sharing some of that from Rowsey, because he is a rouser of unbelievable. And John Williams in Georgia did a fellowship with him, and there's 33 fellows I think he had. But what an amazing legacy to have a fellowship. And so I'm looking for who's the next fellowship leaders that change the next group of ophthalmologists for the kingdom. And Jim is a great example.
Well, all of you guys are too. I'm looking at Ron Kruger, and had such an impact on me. We roomed together at the academy, and all the work we do with CMDA is pretty much because of Ron challenged me way back when. Very involved with COS, but so many of you guys had such profound impacts on us.
Hi, Craig.
Hi, Dan.
Dan Gold.
Oh, by the way, the gold bags are in honor of Dan Gold.
Yeah, they
we
were named
had to
after me,
celebrate
so
the gold of Dan Gold.
Humbly,
So make sure you
I
thank him, because he inspired that. He's talking on Jubilee, but we had to do the gold bags in honor of Dan Gold.
Oh, mercy. So much of our society is iron sharpening iron and relationships. And I wonder if you might have some pearls that you would share from people that just really influenced you, John Lennox or the McDowells. And then I have a second question that I want to ask, because you gave us an NLT Bible. Is there anything special that you feel about that one?
Dan, you're such a blessing. Let me see if I can find this, because people may not know who they are. And I'm trying to remember where it was in the talk. It must be, sorry, indulge me. where was, oh, I'm sorry, I'm sorry, I'll find it. Let's do light table.
So this is the part, if anybody knows a good joke, let me know and I'll run to you.
I just, oh, yeah, here you go. Just so, mirror slideshow. So, this is, oh, it's not coming up. Can we pull up the screen?
No, it's there.
Okay, so for those that are not familiar, this is Sean McDowell's his wife, Stephanie. Many of you probably know Josh McDowell. This is John Lennox. He's a very renowned apologist at Oxford, fantastic person. Hugh Ross founded Reasons. And one of my favorite stories, when I get together with these, I've been privileged to train by some of these really great people. And John is really dear, and thank you, Dan, for the privilege to tell this story. So I always like asking him, what's your favorite pearls? What do you got of pearls? And so John and Sally, his wife, took Amy and I to a nice poobah's place there in Oxford. You know, it's like where the royalty hang out, and we're having coffee and crumpets and whatever. And I asked John, so John, what's one of your favorite pearls? And he's done all kinds of work behind the Iron Curtain and stuff. And he just looked at me, he said, you know, Craig, did it ever bother you that, you know, it says in Timothy, always be ready to give an answer for those that ask you, but they're not asking you any questions? I said, yeah, they're not asking. And I'm looking at him like, where's he going with this? He says, you know, that always bothers me too. And then he says, you know what I do? And now he's got me on the edge of the seat, and I'm just leaning for it. He says, I just keep asking them a question until they ask me one. It's a great pearl. So, and Sean, he always said, when I asked his favorite pearl, he says, you know, so it's similar to the idea that never make an assertion when a question will make the same point. But Sean always says, humble inquiry with asking questions is the most artful, loving thing that you can do. And he really knows apologetics really, really well, and was privileged to study under that. The second thing, Dan, I'm so glad that you asked. So thank him for the gold bags. So in your Bibles that you got, the NLT Illustrated Study Bible, late John MacArthur would tell you, this is the best all-in-one Bible ever made. It has 25,000 text and study notes. And what I would just ask you to do, kindly, is go to each of these pages that are listed in your trifold just to get an overview so you get an idea of the sampling of the resources in it. It has all kinds of timelines in it. It always grounds you. It has maps like you won't believe. There's things in there that I didn't reference, like where did Jesus do his miracles? It has maps for that. It is really fantastic, and you use it as a commentary. So I love New American Standard, but frequently I'll have this open and look on it. I'm like, oh, well, what does that mean there? But it's really fantastic. The second best one is the ESV Study Bible. It also has 25,000 section notes, but you'll find that this one is much more comprehensive, and it has tons of illustrations. All the VIP donors for CMDA, if they pledge a certain amount, they get a copy. All the trustees get that, and we make sure we try to put it in all our healthcare trainees, and frequently they're like, I'm getting it now, I'm comprehending it. So I hope you'll indulge it. Please, you know, keep it, use it, and if you like it, we'll figure out ways to get you more. That answer your question, Dan? So thank Dan for the gold bags. Any other questions?
I got it, G.
We don't want to keep you. Ron may have some nice pearls to share. Can I tell a funny Jim Rowsey story?
Sure, go for it.
Okay, so Ron's heard this before. So Jim would always have a dinner where we get together with the fellows, and we do it at the academy. But the story, and I don't know how many of you guys know Mark Terry. So I trained with Jim and Mark. And Mark was trying to actually get me to stay at Oklahoma. Didn't take it, but Jim is a fireball, as Stan said. He's always greeting everybody. He's got a smile on his face as the day is long, and he's always greeting everybody. So one night, it's about 10:30 or so at night, and we called Dr. Terry the doctor of P, pus perforations, problem patients, but we were doing something late. We were operating all the time. Anyway, Jim's talking through. He sees a young man in scrubs, and he's sitting back in the corner. But Jim's always the teacher's like trying to take a drink out of a fire hydrant, learning from Jim. And so he sees this young man, African-American guy, just, very politely leaning against the kind of wall, not trying to be in the way. And he says, well, Melvin? Or what's your name? Melvin? Nice to have you here. So thanks for being engaged. So Jim, all through this complex, whatever we're doing, graft, he's going through teaching all the steps. Ron, you know the story. He's talking through all the little steps, walking all through, going all through it. And so finally we get toward the end of the case, and he says, Melvin, sure is nice having you here. Well, and he says, well, thank you, sir. And Jim says, well, Melvin, where do you rotate to next? Melvin says, wood. He's in the janitorial services working on cleaning floors. Didn't matter. Jim didn't break. He loved. He'd teach anybody any day, all day long.
So I just want to make a quick comment because I thought that was a great presentation, and it also was a reflection of the kind of things that Jim Rowsey taught us and taught you, and in many ways when you were talking and giving some of these little pearls, and I was hearing Jim Rowsey's voice, because it's just the way he was. He would kind of give these little empirical pearls of wisdom. One of the things I remember he used to always say is, people can't steal from you what you willingly give away.
That's right.
And that's like a very profound thought. Like if you have a spirit of generosity and you know that people are very competitive and you just give something to them, you bridge any kind of conflict that might exist where they want to steal something from you or take advantage because you're giving it away. So there are a lot of neat pearls that way, and I think that was really great that you could put that together. So maybe another round of applause for